So here we're going to talk about the bacteria that can cause lower respiratory tract infections. And so when we think about bacteria moving into our lungs, our lower respiratory tract, the first thing that comes into mind is pneumonia. And so we can have atypical lobar pneumonia, which is shown here in the lower lobe of the left lung, and Streptococcus pneumoniae, for example, would be a cause of this. With pneumonia, your alveoli are going to become inflamed, and so you're going to get fluid that's going to fill up the airspace, and this fluid is building up to try to counter the bacteria that is in this area. Now, the bacteria are going to cause damage to your air sacs, to your alveoli, which is going to allow blood to seep in, and it's going to create this red color. So the red color, the heme, is coming from the blood leaking into this area. So we have two different types of bacteria pneumonia, and we're going to have community-acquired as well as nosocomial. So nosocomial, again, is going to be hospital-acquired pneumonia for patients who are debilitated and have a comorbidity typically. That is why they're in the hospital. They're going to cause serious lower respiratory tract infection. And even though we're talking about bacteria here, a variety of organisms can cause pneumonia. So pathogen or community acquired are going to be our classic lobar pneumonia. And it typically will have these four stages where you'll get a acute congestion. This is where you're going to have the bacteria move in. Your white blood cells or your neutrophils will try to contain the bacteria, eliminate the bacteria, and your capillaries, your blood vessels that feed the alveoli, are going to become swollen with these neutrophils. You're then going to have disruption of the airways, and this is going to lead to red hepatization, which basically means that you're getting damage of the area where the infection is of your cells that are lining the airways, and this will allow for blood to seep into those areas, causing the red. Then you have a gray, which is going to be basically the same thing that happens everywhere in your body when you have neutrophils, is you get pus. And the mixture from the pus and the red gives you sort of this gray color. And so these are neutrophils that are dying. They're trying to control the infection, but they are themselves dying as well. And then hopefully you have resolution, and so eventually your other components of the immune system will kick in, and you will be able to control the infection. Now, community-acquired is also referred to as typical. So community-acquired pneumonia with typical pneumonia is going to be caused by our normal flora pathogens primarily. So we have Strep pneumoniae, and we also have Staph aureus that can cause these typical pneumonia presentations. Haemophilus influenza, before the vaccine was available, also was a major cause of pneumonia. So typical pneumonia is what we really think of pneumonia. It's a lobar pneumonia. You're going to have flu-like symptoms, fever, pain, chills. You're going to get purulent sputum. So purulent is pus-forming sputum, and that's because of those neutrophils that are moving in. And this can lead to damage to the lung and the formation of abscesses. Now, we also have atypical pneumonia. And atypical pneumonia is also community-acquired pneumonia, but these are more less severe cases of pneumonia, what we refer to as walking pneumonia. And so these are going to be caused by a different set of bacteria, and one of the more common ones is Mycoplasm pneumoniae. And so these are going to have milder symptoms. You're going to typically have coughing without sputum, so you don't have that massive neutrophil infiltrate. And keep in mind that the immune system can do a lot of damage while they're trying to control the bacteria. They tend to overreact, and in areas such as your airways, you don't want your immune system to overreact. So having this non-purulent cough, non-purulent atypical pneumonia means that you don't have that massive influx of neutrophils. Legionella is causing atypical pneumonia as well. We have our chlamydia philia pneumoniae, or Passati, which is from the bird flu or bird bacterium. And so here's just a picture of different types of pneumonia. You're going to have our lobar pneumonia, which is going to involve usually a single lobe. So that's our typical pneumonia. We have our interstitial pneumonia and bronchopneumonia. Interstitial is going to have a glass-like appearance, looks like little shards of glass. Typically, it's going to be bilateral and symmetrical. Our bronchopneumonia are going to involve the bronchi, so you're going to get patchy bilateral disease, and typically peribronchial cuffing as well is associated with that. So let's talk a little bit about our atypical bacterium. So Chlamydia pneumoniae can cause atypical pneumonia. This is going to be community acquired, so person-to-person spread. Pathogenesis is going to be a persistent cough lasting for weeks, and this can be treated with a tetracycline or erythromycin treatment. Mycoplasm is an interesting bacteria. Mycoplasm is not similar to our gram-positive, gram-negative bacteria. It does not have that typical bacterial cell wall. Instead, it's going to have lipids and cholesterol in its cell membrane. So no peptidoglycan. No LPS. It has cholesterol and lipids. So it's very different. It's a very unique type of structure to mycoplasm. And mycoplasm causes what we really refer to as walking pneumonia. It's going to be about 10% of all pneumonia cases. It's going to be higher in teenagers. And again, the bacteria lack a cell wall, so you can't use your typical arsenal of antibiotics. Penicillin doesn't work on this. Vancomycin does not work on mycoplasm. And so you have to go with a different. The infectious dose, the reason why it's so contagious, because you need less than 100 pathogens to cause an infection. And so this is very infectious bacteria. Now, treatment, again, is going to be tetracycline, erythromycins. None of those cell wall antibiotics will work. You're going to have an insidious onset with mycoplasm. So it's going to take a few days. And then you're going to have an inflammatory response and get your trachea, bronchioles, and bronchi all involved. Your symptoms appear and last up to 14 weeks. So it's a very slow pneumonia, walking pneumonia, very, very slow. And then you can also have other symptoms, malaise, headache, tracheal bronchitis. Sometimes you also have ear infections associated with Mycoplasm pneumoniae. Now, Legionnaire's disease is caused by Legionella pneumonia, and Legionella pneumonia was identified in 1976. It is a normal pathogen or normal bacteria for birds, so it colonizes birds. It's going to be found in fresh water. It lives actually with our one of our brain-eating amoebas, a Acanthamiba. So those are reservoirs for this bacteria. It's going to be transmitted in aerosol. So in that famous Legionella story, you had a group of men who were part of a group called the Legionnaire, and then they went to a hotel, and this hotel had a brand new air conditioning type of unit in which they had these big pools of water on their roof, and they would pump the water through the roof and circulate the water to cool it off. And then they would push this cold air into rooms, so it was very aerosolized. And what happened was that birds that carry this particular bacteria were defecating it into the water, and it was basically aerosolizing the bacteria in the room where these men were. And many of them got infected and many of them died. Now, it is a facultative intracellular parasite, so it's going to attack the lungs and cause a necrotizing pneumonia. You are also going to you're going to have a more typical immune response with your neutrophils infiltrating, for example. This guy is also going to infect your macrophages, and your macrophages that infect have this sort of coiled morphology. The mortality rate is relatively high with respect to atypical pneumonias, about 15%. Now, another important is our hospital-acquired or nosocomial infections with respect to people who are debilitated in hospitals. So people who are debilitated, meaning that they're laying down for a long period of time, you're going to have an increase of enzymes in the saliva. And this increase of enzymes in the saliva are actually going to attack the patient's own protective layers. So you're going to have fibronectin turnover. And fibronectin is important in protecting the pharynx. And so bacteria are able to move in as the fibronectin is getting broken down. And then the bacteria, as they move in, are able to get further into the lungs. So typically, you would have your protection, this yellow fibronectin layer here, so the bacteria cannot colonize. And then the pathogens are going to gain access when that fibronectin layer is removed. So it's considered a nosocomial infection if it occurs 48 hours after admission. Most of these are going to be associated with our normal flora bacterium. So Staph aureus is a common cause of hospital-acquired pneumonia. And Staph aureus, of course, can be antibiotic resistant. So pathogen can be antibiotic resistant as well. You can see here we have a few others. We have Pseudomonas aeruginosa, which can cause hospital-acquired pneumonia. Our Enterobacteriaceae, so that's our E. coli like bacteria. And we have Citrobacter that also can cause our hospital-acquired pneumonia. All right, so we also have whooping cough. So Bordetella pertussis causes whooping cough. This, again, is very highly contagious. Most children who get exposed to Bordetella are getting exposed by somebody who is in close contact with them, a teacher, a daycare provider, another housemate, an adult in the house, a parent. About 80 to 100% of the children that are going to be exposed will become infected. It's a coccobacillus. It's a gram-negative, so it has this pink-red color, has sort of rounded ends. Its only reservoir is human, so human-to-human spread is the way that this guy gets around. It's going to have symptoms similar to a cold, and again, in daycare centers, schools, these pertussis will spread very quickly. So pertussis loves the ciliated cells. It'll attach, it produces its toxin. The toxin is going to destroy the ciliated cells, and it's going to cause a persistent coughing. Mucus is going to build up. It's because the ciliated cells are what cause the mucus to get pushed up and you cough out the phlegm. Well, because this bacteria destroys those ciliated cells, the mucus is going to build up into the lungs, and that's going to be one of the major causes of your lung disease. Your respiratory, your airways get swollen. The incubation period is about 7 to 10 days. It typically, pertussis itself, the actual bacterium, will not disseminate further beyond this point. So you're going to basically have 3 stages. You have your catarrhal stage, and this is where you have your runny nose, sneezing, cold-like symptoms. This is where you're going to be spreading pertussis. And then you have your proximal stage. This is where you're going to be coughing. It can be about 50 times a day for 2 to 4 weeks, so very persistent cough daily for a very long time. And of course, apnea is always going to be a potential side effect, and apnea is going to affect children. This is also the proximal stage where you get that whooping sound. So the whooping sound comes from you cough, and then you're trying to catch a breath in between coughs, so it makes this whooping sound. And then finally, you have a convalescent stage where you have recovery. Convalescent stage is recovery. So the symptoms are going to decrease, and the severity of the coughing will also decrease. Complications are going to be superinfections with strep pneumoniae. Again, they're getting rid of those ciliated cells, and your normal flora strep can then move in. It can also lead to convulsions. You can have anoxia, bleeding. And this is also going to be helpful if you can get antibiotics to treat. Um, at the proximal stage, however, that's when you get that whooping cough. This is where therapy is mostly going to be supportive. And so, very important is vaccination. So, there is a vaccine for pertussis, it's for that toxin, and that will help to prevent your ciliated cells from getting destroyed and from getting severe symptoms associated with pertussis. Anthrax. So we have inhalation anthrax, which is Bacillus anthracis, and this is a gram-positive rod. It is a spore former. You're going to take in spores, ingestion of spores, and the bacteria are going to make their exotoxin, which is going to cause the potential lethal infection of anthrax. So the pathogenesis simply is due to the exotoxin. You're going to have a progressive respiratory distress and cyanosis. You're going to have a massive spread to the central nervous system, and this is going to be followed by death. Anthrax is very, very sensitive to penicillin, so if you do get penicillin treatment, that would be helpful to prevent death associated with inhalation anthrax. And keep in mind, anthrax is everywhere. It's in our soil, and it can also cause skin infections, but that is not the same as inhalation anthrax. Inhalation anthrax is the one that causes severe death.